So 2023, 16th April is celebrated as Voice Day. This theme of this World Voice Day is One World, Many Voice. As one of our colleagues told that since American Head and Neck Society and Otolaryngology Society has recognized this day as World Voice Day, giving the importance to the voice. So voice disorders, or what we call voice abuse and voice related issues, I'm discussing the anatomy and physiology. So to just orient you guys to what is the basic framework of voice box or laryngeal system, and so the theme for this World Voice Day is Lift Your Voice. The motto was, what we saw as motto is one world, many voice. The theme is Lift Your Voice. So I'll be dealing with the anatomy and physiology of larynx. What is anatomy and physiology? Anatomy is the basic framework of any structure, the mechanics of a structure. Physiology how that structure works or functions. So let's start with what is larynx. So today I'm going to deal in following headings. That is introduction, what is laryngeal system, what is a laryngeal framework consist of, how the larynx has developed in a fetus, in a child, when we are born, when in a mother's womb. The histology, the tissues, various tissues in the larynx, the soft tissue of the larynx, various spaces in the larynx, the blood supply, the lymphatic drainage, and the nerve supply. The nervous system is one of the most intricate nervous system in larynx that gives us the ability to produce such variety of sounds. So let's start with introduction. So can you tell me what are the three important functions of larynx? Let's keep it a bit interactive because anatomy is generally very boring. So I'll try to get some answers from you guys. Please tell me, do you know what are the three basic functions what you guys think the larynx does? Respiration, as respiration, voice, but there's an order. What is the priority? What's the main function of protection? That's the protection of. So as we think that common people think that voice box is made for voice. No, the main function of larynx is to protect the airway. Then second is respiration, and third is phonatory. But the anatomy and the arrangement of larynx in adult human benefits phonatory purpose, and it compromises the protective effect of larynx, the protective and respiratory function of larynx. So let's see what's the difference between the larynx what we have and other mammals have. So compared to other mammals, other species, other animals, what you can, the dog, cat, or apes and chimpanzees. So the other mammalian species have a relatively high riding larynx. So what does a high riding larynx means? As larynx is situated much higher in the airway, it is situated next to the nose, so that we breathe in easily. The air goes directly into the breathing system, and it protects the what we call as chances of aspiration or food going into the airway. So in humans, it is admittedly low. The protective quality of that voice or airway is low because it is positioned very low. So the comparative, our throat or voice box is positioned here, but in other animals, it's much higher. So God has given this gift to our newborn child to give him the advantage of survival. Here we can see, you can see a picture of a young adult and a newborn child. The distance between the nose and the distance between the larynx is more in a young adult. That's a disadvantage to breathe. So distance between the larynx and nose is closed. That's very close. So this gives them advantage of protecting their larynx as soon as they are born, and to maintain the airway in a much efficient and better way. So that's the difference. That's how we are actually born, and the larynx comes down and it gives us the function of speech. So what does the framework of larynx consist of? What the larynx is made up of? Light off just that. What is larynx made up of actually? Larynx is made up of a series of cartilaginous structures. And what are these cartilage? Cartilages are similar to bones and they have different quality. Let's see what is that. And what are those cartilages? The important cartilages are thyroid, cricoid, and epiglottis. And there are paired cartilages, small structures like arytenoid, cuneiform, corniculate, radiate. These are present in pairs. That is, there's a left one, there's a right one, and these are single cartilages, single one. Okay. So this is a rough anatomical schematic representation of larynx, where you can see the blue color nasal cavity, the purple color oral cavity, which communicates with the pharyngeal system. It's a common entrance for two highways, where the two highways meet, the breathing and the food meets and comes down, and again that highway diverges into two. That is the anterior larynx, the entry point for the breathing system, and the posterior esophagus, where from where the food passes into the stomach. So that's how the laryngeal framework is. So now getting into the further details of anatomy, it's you can see the framework how it is placed. It's very strategically placed in the in complete airway system. So this is the entry point. It protects, so as well as it functions to produce voice. How does it do that? So it is attached to the rest of the what you call head through this bone called hyoid bone, to the rest of the lungs through this tracheal rings. So we it's a posterior surface or the inner surface of laryngeal system. If you're standing behind the person and seeing this, so there's a thyroid cartilage again, there arytenoid cartilage, two cuneiform cartilages, and the cricoid cartilage, and they are attached in an intricate network with various membranes and ligaments, which allow us to speak, to breathe, and to do many other function apart from that. So like any other joint in the body, like knee joint, elbow joint, there's a synovial joint. Synovial joint is a kind of joint which has a fluid in it, which gives more freedom of mobility, and it gives provides us it more more resonance, more flexibility, and more movement. Freeness, the dexterity of movement is more. So the framework of larynx is made up of, I told you, it's made up of cartilage. Do you know what is hyaline cartilage? There are different types of cartilage in body. Hyaline cartilage, elastic cartilage. So the quality and the elasticity of these cartilage differ. So especially the thyroid, cricoid, and the arytenoid cartilage are made up of hyaline cartilage. It is whiter, it is thicker, it is less elastic compared to the other cartilages system that are cuneiform, small bones, that are small cartilages, corniculate, cuneiform, tritiate, and epiglottis are made up of elastic fibrocartilaginous. They are flexible, very much flexible, they bend a lot, because, and why thyroid and cricoid are made up of hyaline cartilage? Because they need to protect our airway. They are the entry point. If somebody takes a blow, they should protect us from external force. So that's the reason God has made it with a hyaline cartilage, and these structures which are needed for the voice or phonation are made up of elastic cartilage, so that they can manipulate themselves in a better way to produce a beautiful sound. So what's the clinical significance of these cartilages? These hyaline cartilages, as the age increases, as we grow older, this undergoes calcification. The calcium deposits in that. That's the reason the elderly people, the voice changes. Even as we can see, the initial voice when we were young adult gradually changes as we go old, because the calcification deposits and all those stuff. And the calcification has an enhanced chance, gives a way for tumor cells to grow. So let's deal with individual structures. What's the first structure that's the entry point to our airway is epiglottis. Epiglottis is nothing but a leaf-like structure. It's a lid. It's essentially a cap that covers our voice box. Whenever, yes, kind of a stopper, kind of a lid. Whenever we take food, it closes off and directs the foods to the food pipe. And whenever you start breathing, it opens up and directs the air into here. It's intricately connected with different nerves, and those nerves monitor these movements. So it's basically a leaf-like structure. As you can see, it's a leaf-like structure with a broad free end and a small stalk that attaches to the thyroid cartilage. So through a thyroepiglottic ligament. So you might have seen this movie called 300 Spartans or Spartans. Yes or no? So as you remember, the Spartans, they have a big sword with big shield. The shape of the shield is something like this, and this shape is similar to thyroid cartilage shape or thyroid gland shape. The Latin word thyreus means shield, so the name thyroid is derived from the Latin word shield. So let's see what is thyroid cartilage. Thyroid cartilage is one of the largest in the laryngeal system. It's the largest cartilaginous system that is made up of two quadrilateral. You can see one quadrilateral, one rectangular plate, two rectangular plate. They join in the midline and form a thyroid cartilage. It's like a shield, as you can just compare. It's like a shield with two quadrilateral membranes. They have two horns for attachment, the rest of the body for the upper body, for the head, and to the neck. So generally when these two cartilages join in the midline, there's a small prominence we generally feel. That's called Adam's apple. It's more prominent in males compared to females because of angulation. The angulation differs in males and females. Thus the pitch and the quality of voice changes in males and females. So it's called superior thyroid notch, scientifically, or Adam's apple in a routine layman terms language. So these are two quadrilateral movements. So this is a lateral view where you can see from side when we are standing next to a person and see. So this is the thyroid cartilage, this is the Adam's apple or laryngeal prominence, the inferior horns, the superior horns that give attachment to different structures. There's an oblique line where different muscles are attached. Our strap muscles, that neck muscles are attached so that our larynx is protected quite nicely. So internal surface we are seeing from the inner side, it's a smooth surface structure is lined by a mucosa or skin of mucosa, and which has concavity inside it. So it accommodates different structures in it so that that can properly function. So there are three important attachments here we can see. The three important attachments are, the first point is where the epiglottis attaches as a lid. It's a small stalk attaches like a lid. The second point is where false vocal cords. Do you know false vocal cords? Vestibular fold, right? Vestibular fold attaches, and the third point is where the true vocal cords attach. The real vocal cords, what you use to talk. So this approximately around within 0.5 to 1 centimeter from the superior thyroid notch is the point where these cords get attached, right? So that I was talking about the angle. The angle of union is different between male and female. In males, it's around 90 degrees. It's more acute angle. That's the reason we have more harsh voice. We don't have high pitch voice. Male voice is not high pitch. It's more harsh and more loud. Female voice is high pitch voice because of this angle. The angulation changes. It's simple. I can't just say simple physics. It's a complicated physics. It involves a lot of scientific principles like Bernoulli's effect and etc. etc. So as I told, the lateral attachment, the lateral view of this cartilage shows attachment of different muscles: sternothyroid, the thyrohyoid, and the attachment of thyropharyngeus of inferior constrictor. This is a pharyngeal muscle. This is a muscle that we use for swallowing, right? So that muscle is also attached to this laryngeal system. So do you know what is this? Can anyone tell? What is this? It's a ring. It's a signet ring. If I call it specifically, it's a signet ring. In European society, and probably not in European, even in Indian society or previous old timers, they used to have this kind of engravement of their names or family initials on the ring. It's a mark of status, or it's mark of their family name that they carry on the ring. It's a signet ring, with a signature on it. A ring with a signature. So why do we see that? The signet ring shape is this. What is this? This is a cricoid cartilage. Cricoid cartilage is similar in that shape. It's a signet ring like structure. So cricoid cartilage is one of the unique. It's very unique in complete airway. It's a only intact ring. If you take complete airway from larynx to trachea and bronchi, it's the only ring that is completely intact. It's a complete circular ring. So it provides support to entire airway as well as laryngeal system. So the shape of, as I told, the shape is similar to a signet ring. So the anterior it is narrow, posterior it is wide, and the posterior width is to protect the airway from posterior. Anteriorly, thyroid cartilage is doing that. From posterior side, this posterior lamina of cricoid cartilage is protecting the airway. So we can see different attachments. So post-cricoid region, post-cricoid region, you know post-cricoid region? Do you have any idea? Post-cricoid region is the region behind the cricoid cartilage. We have two tubes, right? Airway and a esophagus running parallelly. So post-cricoid area is a transition area where hypopharynx, where the pharynx converts into esophagus. So that's a very important area where the esophagus actually origins. We can see the attachment, the origin of esophagus, longitudinal fibers of esophagus. We can see the origin of posterior cricoidnoid. So you know the importance of posterior cricoidnoid? Anyone? Posterior cricoidnoid is the only abductor. Yes or no? It's the only abductor, and it's a most important, one of the most important muscles. It's only abductor. It moves the cord. It separates the cords. It is an opener of glottis, right? It opens the glottis. It's the only muscle that opens the glottis. Rest of them are close the glottis. So it's one of the most important muscles, and as attachment for cricothyroid. As I said, cricothyroid is another important muscle that controls the pitch, especially the singers, as you told. It's the most important muscle that lengthens and shortens the cord. So it acts. When it contracts, it stretches the cord, it lengthens the cord. When it relaxes, it shortens the cord. So there's another important cartilage called arytenoid cartilage that is placed over the top of cricoid cartilage here. So this is a triangular cartilage with different processes in it for attachment. Muscular process for the attachment of muscles, vocal process for the attachment of the main vocal ligament or vocal muscle, and facet for attachment to the cricoid cartilage. So we'll see further small, as I told, corniculate and cuneiform cartilage. What corniculate is conical nodules, these small conical nodules that are attached to the apex of the arytenoid. And cuneiform are two elongated club shape. Clubs, right? We juggle the clubs. So these are club shaped nodules that are present in aryepiglottic fold. And tritiate cartilage are on the sides of this. This will show you the arrangement of these cartilages. There's a arytenoid cartilage, there's a corniculate cartilage over the apex of it, and there's a cuneiform cartilage. All these angulations do matter. All these attachments and angulations, they appear some sort of like a cap, but all these things help in mobility of our vocal cords, right? So these are tritial cartilages that are in the lateral part of the thyroid ligament. Let's know about the embryology. How does our larynx originates in when we are in the fetal stage, when we are in the mother's womb? How does it originate? So all these structures, this is just a rod. Initially, at the time before when we are in the fetal stage, the human body is like a stem. Do you know that? It's just like a small mass, and those mass again divides into many small round like structure called as branchial. You know them, arches, pouches. You have heard about them, right? So all these pouches give to different structures. Arches give to different structures. Some of pouches are made for internal organs, and arches are made for developing muscles and etc. So essentially, as this diagram depicts, the thyroid, the larynx develops from fourth and sixth arches. What are the fourth and sixth arches? So even the supraglottic area, the region above our vocal cords, develop from buccopharyngeal primordium. The third and fourth arches, and glottic and subglottis develop from sixth branchial arches. So this development has a uniqueness to it, and because this develops from a different aspect from where our mouth develops. The supraglottic area above the vocal cord area develops from an area from where mouth, jaw, and all these happen. So the blood supply is different. Therefore, the larynx has dual blood supply. The advantage God has given is it has two blood supply. Generally, every organ has one main blood supply, but the advantage of this is it is made from 3 to 4 different structures. So it has two blood supplies. Even one compromises, the other takes a function. So even the nerve supply is intricate. The supraglottis is supplied to superior laryngeal. The glottis and subglottis is supplied by inferior laryngeal arteries. So that's how the intricate network of blood vessels around the larynx gives us the nourishment, gives the laryngeal system a nourishment, right? So what is the importance of this thing? Glottis is a paired structure which is developed from two different sites and joins in the midline. So, and it is very sparse in lymph node. So generally especially what is the clinical relevances? People who develop voice box cancers, people start telling that they come with, I have a change in voice. This is the earliest sign of a patient having a vocal cord issues. If there is a change in voice that doesn't come back to normal within next 15 to 20 days, it means that there is an issue in your vocal cord. There is some issue in your vocal cord, and God has given that gift that generally these people present very early. So they have very good chances of cure and very good chance of restoring their voice. So that's the advantage of it, and they are clinically related, more of in cancer patients. Especially supraglottis lesions, the lesions above the vocal cords have more chances of having a lymph node. They present more with lymph nodes, while glottic lesions present with change in voice as the earliest symptom. So let's deal with the histology. What is the histology? What is the main type of epithelium? What type of skin does the laryngeal system is lined with? So respiratory epithelium is generally pseudostratified epithelium. What is pseudostratified epithelium? Does anybody know? Pseudostratified epithelium. These are tall cells. They are cells which have hair, like hair on its surface to clear the secretions, and they secrete lot of mucus. So when these Fibers, yes. They're cells with hair on it. You can imagine our head like cell with a hair. Whenever the mucus comes on it, it washes it away. There's a movement of cilia. There's a direction of flow. So generally, respiratory epithelium is like that's the reason we try to cough out all secretions. Whatever something goes in our, we cuff it, and that's how the cilia drives it out. So, but vocal cord is a unique region where it is lined by a non-keratinized stratified squamous epithelium. What is the importance of it? Non-stratified squamous epithelium. It's like a Teflon coating. It's like a non-stick coat. So when we speak, if for suppose if our vocal cords were lined with a respiratory or ciliated epithelium, all the cilia will entangle and our voice will be like a gurgling voice. If you're taking a bit of water in your mouth and start speaking, that's like gurgling voice. So God has not given secretions at that very point where we need to speak. The vocal cords, the area where the maximum vibration occurs, or the area where we use for speaking. So that is lined by a non-stick coating. We can say that as in a layman's term as a non-stick coating of non-keratinized stratified epithelium. It bears lot of trauma. Whenever we speak, whenever we scream, it undergoes lot of friction, mechanical trauma. So apart from that, these things are also these epithelium is replaced continuously. How frequent is it replaced? Do you know? How frequently the epithelium is replaced? How frequently the vocal cord epithelium? Yes, yes. Vibration cords. It changes regularly. The damage the god has given the auto servicing mechanism. So what we can say that whenever we speak harsh, whenever we scream, there's a lot of mechanical trauma. All those superficial cells get damaged, they get replaced also. Oh, that depends on that depends. I can't tell you, but generally, if there is some surgical, what we do, this around 15 days is approximate time where they generally heal, heal, and 1 month is the time they develop. Microscopic, we it depends on the it's the life cycle is. Oh, even I have to like look out that. So it's frequently replaced. The yes, yes, yes. Recovery time. So there are two recovery time is again how much you try to help your voice after you have done such a stuff. There are vocal hygiene, the vocal exercises that you have to do to recover faster. Those things we that they are a complex thing. I think sir would give a better idea rather than me. More. So it's more of friction. You can say more of friction. That probably you have to take more precautions and do some what we call as post assaults. Yes, yes, all these stuff will give them voice rest and all the stuff. That will help you in recovery, faster recovery rather than I can say faster recovery. So even the external surfaces where the larynx, where the food enters, the epiglottis and the areas where the food and other things are dealt with is also supplied by this non-stick, non-keratinized, non-squamous epithelium, where it bears the stress, it bears the mechanism or what we call as mechanical trauma. So it's a small clip where we can see how the cartilaginous systems, we can see here the hyoid bone here, the thyroid cartilage here, the epiglottis, the cricoid, the arytenoid on one side, on opposite side, the what corniculate, cuneiform and corniculate, other way around, and all these things join in a three-dimensional way to form a larynx. So what are the various soft tissues in larynx? What are the various soft tissues in larynx and what is the importance? So membranes and ligaments. It's nothing but membranes and ligaments that make up the internal larynx. So there are two types of in this, extrinsic and intrinsic. What is extrinsic? What is intrinsic? Does anybody know? Intrinsic, extrinsic. The simple the word means. Yes, externally. The things that connect them externally, the things that connect them internally. Simple. So let's see what are the extrinsic membranes and what are the intrinsic membranes. So here is a rough anatomic picture. There's a normal cross section. We have taken it in the midline. You can see the hyoid bone. It suspends this larynx from a small sheet. This sheet-like structure. Probably you can call it's like a curtain-like structure. This is a ligament. This is a membrane called thyrohyoid membrane that suspends, that holds that larynx. from the hyoid bone. Hyoid bone is also an important structure that gives us strength when we speak, when we swallow. It moves our larynx as a whole system. So that's the reason it's held by a membrane. And another membrane that connects our larynx from the lower, from the lungs, is cricotracheal ligament and membrane. So here we can, it's another diagram where you can see the external extrinsic membrane, thyroid membrane, as I told, from the hyoid, cricotracheal membrane, that is from, this is cricoid cartilage, and this cricotracheal membrane would be here. And another important one is hyoepiglottic and thyroepiglottic membrane. Epiglottis is a lead, right? Lead has to be connected to two different, one to pull, one to push. So these are thyroepiglottic and hyoepiglottic ligaments or membranes. So coming to the intrinsic membranes, these intrinsic membranes are very much important. They form the basis of vocal cords. So they form the inner lamina, what we call the pillars of vocal cords or voice box. So what are those membranes? These are fibroelastic membrane. So again, elasticity is most important thing here. So that's why these are fibroelastic. They are thin like a cloth, but again they're elastic, so they can stretch. So fibroelastic membranes, they are basically two membranes, one in the upper part, one in the lower part. The upper part is quadrangular membrane, the lower part is conus elasticus. So here in the diagram we can see there's a quadrangular membrane, extends from the epiglottis to the arytenoid and the free edge. And the free edge is called as vestibular ligament. The false vocal cord. Vestibular ligament is the basis of false vocal cord. It's like a sheet, it's like a thin sheet which is elastic and which moves with the structures. And another membrane is a conus elasticus. Conus elasticus is a membrane that extends from inferiorly from the cricoid cartilage and ends as a thickening called vocal ligament. Vocal ligament is the voice cord, vocal cord is the basis of vocal cord. It's a complex structure. We'll see how it evolves. So quadrangular membrane, where it attaches to, basically it attaches to the free edge of epiglottis. It holds the epiglottis with two edges. Whenever it's required, it pulls it and closes it. So it extends from free edge of epiglottis to the arytenoid, and this is called as aryepiglottic ligament, which forms the aryepiglottic fold. The ligament covered with an mucosa forms a aryepiglottic fold, which is important for closure of the larynx. Suddenly, if you are eating something and you try to speak, right? At that time, this aryepiglottic thing comes into play and shuts your larynx. So it avoids the food from going into your larynx. So that's it. Now conus elasticus. Conus elasticus is another interesting membrane. It's why the name conus elasticus. It has other synonyms called cricovocal membrane and cricothyroid membrane. So the name show that it cricothyroid means it arises from cricoid, attaches to the thyroid, and cricovocal membrane means it vocal cord. It's a vocal cord. So it's a funnel shape. The name conus elasticus. Conus means cone. Conus elasticus comes from the cone shape appearance. It's like a cone which is running from cricoid and goes to the vocal ligament, right? So why is that arrangement? I will see that diagram. Why is that arrangement like that? So then again, soft tissue of larynx, conus elasticus, as I told, derives its name from cone shape or funnel shape thing, and it drives the air. Whatever the air we have in our lungs, it has to be driven to our voice box. And there is a principle called Bernoulli's principle, where the pressure and velocity are two different things, where the voice modulation comes like that. In lungs, we have lot of air pressure. It has to be channeled to our voice box. If the same amount of pressure goes to our larynx, it will shatter. So the God has made a funnel-like structure where the air goes in a faster way. The velocity is more, but the pressure is very less. That's the reason we can modulate. That's the reason how singers probably modulate their voice, different pitches and etc. etc. That's the basic mechanism. And when it comes out, again the pressure increases and it appears as a loud sound. That's the effect. So now we come to the paraluminal spaces. Again, why these paraluminal spaces are important? These paraluminal spaces are very much important to understand any pathology in a larynx. Especially, I'll tell you, there are three important paraluminal spaces. Paraluminal spaces are the spaces between the cartilages and the membranes. what we've discussed, the quadrangular and conus elasticus membrane. There are pre-epiglottic space, paraglottic space, and subglottic space. So these are also important for, they are also important regions for spreading of tumors. So what is pre-epiglottic space? As the name suggests, it's pre-epiglottis, in front of epiglottis, right? So it's a pre-epiglottic space is a space that is in front of epiglottis. We can say this is epiglottis, this is a lid, this is ariepiglottic fold, this is pre-epiglottic space. The anterior is covered by thyrohyoid membrane. The name itself shows us the function of that membrane. It attaches hyoid to thyroid. Anterior is covered by thyrohyoid membrane, laterally by the thyroid membrane and cartilage, and I mean to say laterally, posteriorly by epiglottis, superiorly by hyoepiglottic ligament, and laterally this space communicates freely with the paraglottic space. Paraglottic space is another paraluminal space, right? So this diagram you can probably appreciate. This is hyoepiglottic ligament, this is thyroid ligament, this is pre-epiglottic space which contains fat, right? And this literally it communicates with the paraglottic space. Now coming to the paraglottic space, where you can see paraglottic space is bounded by thyroid cartilage laterally and the mucosa of vocal cords, the quadrangular membrane medially, right? And it communicates posteriorly with the pyriform sinus. Pyriform sinus are the two sinuses that channel the food into our esophagus, right? So this is a clinical significance of paraglottic space. A small lesion can go into paraglottic space and the stage of the tumor changes. If a patient comes, says that there's a voice change, I'm not able to speak normally, or my voice intensity or frequency has changed. If you do a examination and you see that there's nothing on the vocal cord, you have to suspect that there is something in the paraglottic space because it is trying to push on the vocal cords, right? So you have to do an imaging, a CT scan or MRI to check out that thing. So another space is subglottic space. Subglottic space again is an important place where this is the narrowest part of the larynx, where the generally it is the place from where the air is channeled out into the vocal cord and from vocal cord into the oral cavity, right? So it's a space between the mucous membrane here and what we called as conus elasticus, right? That's a common place where generally people get a lot of edema, subglottic, and it causes breathing difficulty. So now coming to laryngeal cavity as a whole, laryngeal cavity starts from the laryngeal inlet and ends at the lower border of cricoid cartilage, and it is divided into two parts, essentially two parts, upper and lower, and there's another middle part. It's like a big curtain divided in between by a small space, right? So the upper fold is called vestibular fold or a false vocal fold, right? This upper fold, I'll just zoom in, right? This is called vestibular fold. This is empty space. Actually an empty space opens up into cavity like this. This is vestibular fold or false vocal cord. Anything? No. Vestibular space. This is a kind of space. This is an empty space actually. It is lined by mucus. So how our vocal cords get lubricated? How these Teflon coated non-stick parts get lubricated is whenever we speak, we have dryness of throat. We try to drink water and stuff. So this is a place where the glands lie. Small salivary glands will be there. They secrete the mucosa. They secrete that small saliva and they pour onto this vocal cords. These are generally don't have their own secretion. So they pour in, they lubricate them like anything, like applying a grease on a simple thing, simple mechanism. Only thing is there's a space that pours into the secretions into this thing. So especially singers have something to do with this space. I'll come on to that. Singers and musicians who play instrument, flute, trumpet, Shehnai. Yes, wind instruments. I'll come to that. So space between these two cords called rima vestibuli. And rima vestibuli, people use false cords to speak. You know that? There's a people use false cords to speak. So especially in your profession, you people do use to modulate the sound. And there are people who have neurological issues. They also use, instead of using a true vocal cord, they use false vocal cord to speak. It's called pseudo speech. You know that, right? Are you sleeping? No. So it's boring actually. It's boring for me also. So these are true vocal cords. As I told you, these are true vocal folds. The basis of this is conus elasticus, as you can see. Conus elasticus forms a vocal ligament, and the mucosa over it forms a vocal fold. It's nothing but a ligament draped by a mucosa, a bed sheet, right? In a simpler terms. So laryngeal cavity, entire laryngeal system is divided into three subunits. Why it is divided into three subunits? Because every subunit has an intricate function as well as intricate mechanism, intricate anatomy. Okay, the first is supraglottis. Supraglottis system is from epiglottis just above the just above the superior surface of vocal cords. From superior surface of vocal cord, one centimeter below is the glottis, is the main area where the vocal cords are located, and below it till the lower border of cricoid is subglottis, right? Subglottis is the essential area where the air we breathe in goes is transferred to the lungs, right? What are mucosal folds? As I told, these are mucosal folds are nothing but the ligaments and all these membranes covered by mucosa. What are the two most important mucosal folds? As I told, vestibular fold and vocal fold. And vocal fold, now let's discuss about vocal fold. Vocal fold because we use for phonation and etc. What is vocal fold? Vocal fold is a vocal ligament covered by mucosa and it is joined by lamina propria. Lamina propria is one of the most important things. Generally, when child at birth, the lamina propria is made of a single layer and it grows to 3 layers at the age of 7 years. The lamina propria is comprised of 3 layers: superficial, intermediate, and deep. This is the basic model given by Hirano. It's called body and cover model. It's more important for people who deal with voice, right? That's the reason how we modulate our voice. There's a body and cover model is the most important explanation for these, how we produce voice, right? So most superficial consists of a loose collagen and elastic. Again, you have to see the composition. That's most important. Loose collagen and elastic fibers give it the flexibility, give it the movement, give it the nature of sliding over the hard surfaces. So intermediate and deep layer are combined to form vocal ligament. Okay, these two layers, intermediate as well as deep layer, combined to form a vocal ligament. And the space is called as rinky space. Do you know rinky's edema? Especially people who smoke a lot, they develop a edema. They develop water. They get a lot of water in this space called rinky's edema. More common in smokers, right? And the muscle, the thyroarytenoid or the vocalis muscle, forms the innermost layer that controls the cord length and thickness, right? So let's see. This is a model described by Hirano. So the innermost is muscle. Okay, it's like onion peel, right? So different layers of onion. The innermost is the main thing, the main muscle that controls the length, breadth of vocal cord. Then it's a vocal ligament. Vocal ligament is formed by intermediate and deep layer of lamina propria, right? So that's more of tough tissue, and the superficial to it is superficial lamina propria. It has more of elastic and collagen, loose collagen, and this is epithelium, the non-stick coating. So this non-stick coating has to move over it, to vibrate. If air is coming, if it has to vibrate, it has to be mobile. So this sheet gives them that mobility. That jelly, it's like a jelly-like sheet that helps it in movement. And the inner things are, it's bit tough. So it's a loose jelly, tough layer, and again a coating. So that's how the mucosa moves over the vocal cord. That creates the vibrations actually. It's another picture where we can see the muscle, the vocal ligament comprised of intermediate and deep and superficial lamina propria and squamous epithelium, the non-stick coating, right? So it's just a rough classification what we for laser surgeries when we do, especially in cancer patient or we do surgeries, we do conservative laryngeal surgeries, especially to preserve their voice. So these are various types of surgery. The amount we set, you have to just roughly remember that there are 5 types of conservative laryngeal surgeries, right? Because when you see in a OPD prescription, you don't understand what is what. Just to remember that if somebody does a laser surgery, and these are the 5 types of surgeries. And after that, you can probably look into the book or Google it, that what we have removed exactly. They are classified according to the amount of tissue removed, right? So what's the clinical significance of this vocal ligament or vocal fold is the point at which vocal ligament attaches to the thyroid cartilage is an essential point. Initially we saw that there are 3 points like Epiglottic attachment, false vocal cord attachment, and true vocal cord attachment is the point where it's called as Broyles ligament. It merges into the cartilage. So it's the more least resistant point where we can say that malignancy can spread easily. So you have to be careful, especially people who come, smokers who come with early lesions, changing there's a voice change and this, and look, the lesion is located anteriorly. We should be careful that this might have an effect on the cartilaginous system. And I'll just, so this is a normal endoscopic picture. When you do an endoscopy on OPD basis, this is how we see a larynx. As I told, these are true vocal cords, vocal folds. I can say vocal fold, and these are macula flava. These are called macula, yellowish spots where we can see a macula flava. These are arytenoids, and this is the subglottic region. The false vocal cord will be somewhere like this, and this is actually a potential space. We don't see it. We have to lift it to see it, but there's a space above it from where the mucosa pours it becomes wet, and so that how we speak. So I was telling you that empty space. This is the empty space. We call it as ventricle of larynx, laryngeal ventricle. It's also called as laryngeal sinus. What's the importance of this is it contains many salivary glands, many small minor salivary glands that produce saliva to lubricate our respiratory system, to ventilate, to cool the air, as well as to lubricate our voice box, right? So it opens up anteriorly. It's a blind fold. It's a blind fold that goes anteriorly, opens into saccule. We'll come to that saccule. What is saccule? Saccule is another important thing. So this is the blind fold. It's covered. It's like a sheet. Goes there and opens into saccule. Saccule is like nothing but a sac. What is saccule of larynx? Saccule is a pouch of variable size between the vestibular fold and thyroid cartilage. Somewhere here. So this is do you know what is this? It's a laryngocele. It's a laryngocele. It's a swelling of that vestibular fold, the saccule. The fluid, the secretions have accumulated in it. One of the glands might be secreting. It was not able to outpour them, so they've accumulated those secretions, and it has grown into something like this. It has spouted outside. Okay. So I'll just show you something interesting. Do you see this? I'm sorry. Do you see this? This is a laryngocele, especially people who play these wind instruments, Shehnai, people who play these trumpets, people who play flutes. They have the chance of developing this laryngocele because they have to put a lot of pressure to blow air. So this is something related to cancer. I can say this is a transglottic cancer. It's cancer that involves all the areas of the laryngeal system. I don't think so. That's much relevant here. Coming to blood supply, how the blood is supplied to these laryngeal skeleton. Here we see the main arteries, the carotids, from where the blood supply goes in. The main supply is by superior laryngeal artery. The name indicates that it supplies the larynx. It's a branch of superior thyroid artery, which gives. Here we can see, right? This is superior thyroid artery, and it gives a superior laryngeal artery and other further branches to different other structures, right? So again, then another blood supply. I told you it's a dual blood supply. That is, inferior laryngeal artery is also another supply, an important vessel that supplies the laryngeal system, which is again a direct branch of subclavian, the arch of aorta, and a direct branch of subclavian. So this dual blood supply provides protects it from in any case of calamities or any surgery. Sometimes we do thyroid surgeries. If we have to ligate the superior thyroid on one side, the opposite side takes care of it, or the inferior thyroid takes care of it. The anastomose like a meshwork, like a mesh around the larynx, right? And the venous outtake is from the same vessel, superior laryngeal and inferior laryngeal supply, right? So what's the clinical significance of these supplies? Whenever we are doing an endoscopic approach, there's a lot of blood flow that might be from the superior laryngeal artery branch, and we have to just ligate in the neck. So lymphatic drainage again is important. Lymphatic drainage is whenever we have a pathology, a problem in our body, there's always a lymphatic system. We have tonsils. As soon as we have tonsils, we have a toothache or a caries of tooth, we have small nodes. These are indicators in body. These are early indicators. God has given some indicators. You might not know before, even before the infection comes there, it has to lodge there. So it is, these are indicators as well as they are generators of immune system. They make, they introduce the foreign body to our immune system, make cells for them, white blood cells for them, and kill them. As well as they are indicators that you should take care. There is some problem, please go to a doctor, please do something to relieve it. So lymphatic system is another important thing, where the lymph is drained from the laryngeal system and goes to different lymphatic nodes. And this lymphatic nodes are importance that if the supraglottic is a rich lymphatic system, whenever a patient has some lesion, some infection, even cancer of supraglottic area, they'll present with a node first. Rather than the primary complaint, they'll have a node first. So that's an early indicator that there is something that you should look out that area, right? Coming to the innervation of larynx, larynx is innervated by internal and external branches of superior laryngeal nerve and recurrent laryngeal nerve. These are two most important nerves you should remember actually. Superior laryngeal nerve has two branches, internal and external. Internal branch is sensory, right? A sensory, and external branch is motor, recurrent is a mixed nerve. Internal branch is sensory till the vocal cords, and below the vocal cords, recurrent laryngeal nerve takes care of it. The sensation of larynx has two nerve supplies. Above it, one nerve takes care. Below it, one nerve takes care of it. How does it function? Especially when we are eating, when you are talking simultaneously, something goes up in your food pipe, you try to cough it up. Why? Because we have sensation there. We have sensation that something is going in. It's a protective mechanism that we cough it out. So that sensation is by this nerve, internal laryngeal nerve. If something goes much below, even though we try to cough a lot, if something goes into the trachea, we cough a lot because of this sensation, because of recurrent laryngeal. The inferior part is provided with that. So here we can see the innervation of different nerves going to different parts of larynx. They form a Gallen's anastomosis in the posterior part of the larynx. It's a very intricate network, especially very important network that affects the voice, that affects the movement of the muscle and thereby the voice. So superior laryngeal nerve, do you know superior laryngeal nerve? What is the importance of superior laryngeal nerve? It's a sensation, right? Apart from that, there's another important, these guys, especially speech language pathologists, deal with it day in, day out. Especially the thyroid patients, thyroid surgery, who undergo thyroid surgeries, have an issue with this. I'll just come to that. So this is how the superior laryngeal nerve arises from our ganglias, vagus ganglion, and gives the different supplies, right? So I'll not go into the details, it's very much boring. Actually, even we have to revise it repeatedly to remember it. So it's, I can tell you the internal, as I said, it's an afferent for cuff reflex. It's a sensation for cuff reflex. Okay, and sure. External laryngeal nerve. This is an important branch of superior laryngeal nerve. Superior laryngeal nerve has an internal as well as external branch, right? So there's a beautiful history with this nerve. Does anyone knows? Do anyone know? What is the history associated with this nerve? Yes, I'll just. External branch of superior laryngeal nerve. I'll come to that. It controls the timbre, the sound quality, the pitch of voice. You recognize her? Probably, I don't know. She is a famous soprano singer. She's from Italy. Probably in 1920s and 1920s. She used to, opera or soprano, you can call. It's a high pitched voice. Probably the people used to listen. Your old movies you might have seen, old English movies. They'll be singing a very high pitch. So she was one of the famous singer of that times, Amelita Gallicursi. So she underwent, she had this thyroid mass in her neck. I'll just show you. So there's a thyroid mass in her neck. She was been carrying that for probably around 20 years. But later in her career, because of that mass, there was a pressure on her what we call trachea, not vocal cord, on her breathing system. She was not able to take the breath while in between the singing. So she finally wanted to get it operated. She went to different doctors. Everybody denied it because she was a singer. So that's the biggest, they were scared of it. So finally in US in 1927, I think, in Chicago, one of the doctors operated her. So he denied of giving her general anesthesia. He asked her to sing while he was operating on her to check whether nerve is working or not. She was operated in local anesthesia. Just given a local here and she was operated, and in between the surgery he was asked to sing so that he wanted to ensure that the nerve is functioning or not. So that came out to around 200 grams of mass on the same side. He operated.
For 20 years it didn't affect, it didn't
No,
manifest
it
anything.
gradually it was gradually growing. He neglected it. When it affected her singing, she started to she wanted to get it removed. So she was operated under low. This is a real picture of her in the post-op period at that time in Chicago. So post-operatively, when she again went back to, after probably 6 7 months, she went back to an opera in Europe. The music critic said that she was not able to carry out the highest pitch because of injury to that nerve called external branch of superior laryngeal that controls the pitch of timbre of the voice. So that's the history behind that nerve, and since then it has been named after her, and people take care of it, especially in thyroid surgeries. We have latest technology to use. Do you know nerve monitoring system? So there's a nerve monitoring system where whenever we go near it's like a lie detector. Whenever we go near the nerve, it makes a sound that there's a nerve. It makes a siren as of. So when we use intraoperatively, we put something of a thread is there. We just put it on it. If it rings up, then probably it's a nerve. So that's how we preserve and protect now. It's mostly anatomical knowledge. Apart from that, it's the latest technology that we use. We have it here. We use for the thyroidectomy patients to preserve their voice. So it's recurrent laryngeal nerve is the most important nerve that supplies almost all muscular system in the laryngeal system, except for one muscle, that is cricothyroid muscle. And this is the muscle that controls our respiration, our breathing, right? This moves the vocal cord and that controls the. So this mainly the rough algorithm of. So I'll just brush it. So here these are the what we call different scenarios of vocal cord palsy. Normal vocal cord while respiration, while phonation. Unilateral palsy, if there is a palsy of one side, there will be compromise, it will not close. Respiration, bilateral palsy, the vocal cords will be in the paramedian position, right? They will not move much, so there will be no difference while they are speaking or respiring. The voice will be breathy voice, as if they are just airy voice, just like that. So they can't speak more than that. So recurrent laryngeal palsy, yes, it occurs in neurological patient as well as the most apart from that is any injury to the vagus anywhere and surgically, iatrogenic. Does it during a surgery of thyroid. So that we should be very much careful. And yes,
Sir, you showed about the bilateral, right? The vocal cords, the normal and the
yes, yes.
palsy affected.
Palsy, right?
No, after that.
After that.
There is three layer
Huh.
RBS.
Huh.
Is bilateral paralysis, this is paralysis totally.
Yes, yes.
Because what I came across is like when you have a nodule on your vocal cords,
Hmm.
that time also the closure is not possible.
Closure is not possible, and when you try to close it, there will be friction. There is some sort of discomfort you will feel, and especially singers have singer nodules. They have nodules on both vocal cords, the point where both touches. So they over a time they develop a hard keratinous material there. So that's how they have to prevent it through vocal hygiene, voice exercises, and other stuff. As you said, that gargling. There's a lot of other yoga and all these the breathing exercises that teach them to have that control on their voice. So you're right. So physiology of larynx, the main function of larynx as we were discussing is in breathing and function in speech. I'll discuss under these headings. In breathing again, motion, protection, cough, control of ventilation, sensory receptor and circulatory receptors, right? Why different all these functions are intricate with larynx is because it's one of the most complicated structure and has uh, one of the complicated nervous supply in human body, I can tell you. Muscles of larynx, what are the muscles of larynx, how they work and how they are attached, we'll just see. A diagrammatic representation is I think much better. There's a list of that extrinsic muscle that attach the larynx from surrounding structures and protect the larynx from external trauma. So intrinsic muscles, mostly the open and close of glottis. Opener is, I told you that posterior cricoid is the most important muscle. This is the only opener of the glottis.
Abductor.
Abductor, abducts it. So it's the only abductor, posterior cricoid. It's supplied by recurrent laryngeal nerve. And other lateral cricoarytenoid, transverse arytenoid, oblique arytenoids, they have different functions of manipulating the cord. And again, control of tension of the cord. Again, I told you cricothyroid and thyroarytenoid. There's two muscles that tension of the cord, the lengthening, the shortening, as well as the tension thickness of the cord is maintained by thyroarytenoid and cricoarytenoid. And other things that alter the laryngeal inlet shape, aryepiglottic fold. It is the the muscle or the fiber that closes the epiglottis, and thyroepiglottis that protects that opens the aryepiglottic, closes the epiglottis, thyroepiglottis pulls opens up the epiglottis. So here we can see a motion, the adduction. What is neutral movement? Generally the vocal cords are a bit apart. That is, this is, if you think is a midline, then vocal cord will be here. There will be some space always in between the vocal cords for the respiration purpose. And there's a movement, abduction, adduction. Abduction when we breathe in, when we try to breathe full breath, it moves away and gives the space to the air. Adduction when you try to speak, right? Adduction helps in producing voice. This is a movement of cricoid. This is cricoid cartilage. This is arytenoid cartilage. This is posterior cricoarytenoid muscle, as I told. When the muscle pulls it, it opens up. The movement, as we see, it's moving farther. The vocal cord is attached here, so these are closed now. When it pulls, the vocal cords move farther. This is the normal physiology. And you see the here you can see the function of thyroarytenoid and cricothyroid. Thyroarytenoid controls the thickness of the muscle, the thickness of the, you see the cords are thick, the thin, and cricothyroid tension of the muscle. When it moves down, it creates a stretch on the cord. It creates a stretch. It was thick and it become thin. Thyroarytenoid, it was thin, it become thick. So these are all five intricate things that change our voice, that control our speech and voice. So we can see a rough picture, diagrammatic representation of attachment of various muscles. This is posterior cricoarytenoid muscle attached to the arytenoid. This is a vocal ligament attached to the vocal process of arytenoid. Lateral cricoarytenoid. The name itself indicates the attachment of the muscles, right? Lateral cricoarytenoid muscle. And posterior cricoarytenoid muscle, thyroid muscle, and transverse arytenoid muscles. So I'll just show a small clip where you see the motions of movement of each muscle, right? So here posterior cricoarytenoid widens it. It's an abductor. It opens up the larynx. Lateral cricoarytenoid. See, when you are exhaling, transverse or oblique arytenoids. When you are speaking, bringing the cord together while phonation. Thyroarytenoid vocalis loosens the cord in the lower pitch. Cricothyroid stretches the cord, increases the pitch, right? Shortening is by thyroarytenoid and lengthening is by cricoarytenoid. So what are the other reflexes? Sorry, the cuff reflex. Cuff reflex is forceful expiration against the laryngeal abductor response. Is a protective response to prevent aspiration. It is preceded by a rapid inspiration. We take a lot of air and then we cough it out. How much air we cough it out? 10 liters per second. 10 liters per second, I mean. That's a very huge amount to wash out the foreign body or whatever we have in our trachea. Control of ventilation. Larynx is located at the entrance of trachea. It controls our breathing, etc. Sensory organ. Larynx is not only a motor, it functions as a sensory organ to inlet of airway. It controls, it checks the temperature of airflow, it controls the pressure of airflow, right? It has different receptors. Such as respiratory receptors, negative pressure receptor, drive receptors. Drive receptors are the receptors that control our respiratory drive. They are connected to our brain. How do we exhale? Inhalation is an active process. Exhalation is a passive process. But how do we control it? It's through these receptors. It's a complex thing, but I think. And circulatory reflex, right? Obstructive sleep apnea patients, generally have negative airway pressure. That's the reason they are not able to breathe. Their breath stops. Okay, and even during general anesthesia, when we stimulate the larynx, it causes bradycardia. It, as soon as we touched it, the heart tries to stop because vagus nerve is stimulated, and because vagus nerve is the main nerve that gives the branches of recurrent and superior laryngeal nerves, right? Effort closure is one of the most important function. This Valsalva maneuver. Whenever we're lifting heavy weights, or we are especially pregnant females giving to childbirth or defecation, abdominal pressure is raised by closed glottis. So we have to lift anything, we have to do exercise, we have to lift a dumbbell, we have to raise the pressure, abdominal pressure, and this is by closing the glottis. It's called Valsalva maneuver, right? So it's another important thing we use day in day to day life, right? And protection of airway while swallowing. This is the most common thing. The primary function of air larynx is to do that. It acts as a sphincter. It closes the larynx. It raises the extrinsic muscle raises the larynx to protect against aspiration, right? And initiation, phonation. When coming to phonation, there are two components: initiation of voice and vibratory cycle. I've just so what are the basic requirement of initiation of voice? Adequate breath, approximation of voice, vocal folds, favorable vibratory properties, favorable vocal fold shape, control of length and tension. There are basic things that are required. So what I was talking was about this principle, Bernoulli's principle, where this is the glottic area, the narrowest area. The lungs push the air, it comes with high velocity, it goes out to the mouth, right? That's how the voice is produced. You might know this. This is a basic principle about for any. You know that it's a mouthpiece, right? Mouthpiece piece for any instrument. Shanai, all these instruments, they all function the same principle. There's a high pressure system. There's a narrow system with which goes with high velocity. Again, there's a high pressure system. The sound comes out, right? So vibratory cycle. I have a small video on the vibratory cycle. How normal stroboscopy appears in these people, right? See, you can appreciate the movement of vocal folds, right? Do you guys see stroboscopy? Do stroboscopy day in day out? Do you see? No? Yes. How many have seen a stroboscopy or do a stroboscopy regularly? As a voice pathologist, I'm telling you, if you are not involved in all these things, clinical, you have to sit with a doctor, understand what he is telling. You have to, then only you give the best results to the patient. And I'm telling you, this is the future. Why? Not only voice, speech, swallowing is a has a very much very large, big future in India. Especially, I've worked in few places where we have a exclusive speech and swallowing pathologist, right? They monitor all our patients. All malignancy patients have issues with their speech as well as swallowing. They have aspiration. So they do fees, they do video fluoroscopy. They sit with the patient, they give them maneuvers, different maneuvers. You know maneuvers, different maneuvers for swallowing? It's in their curriculum, sir. You know maneuvers for speech and swallowing, different maneuvers. So those are very much important in our day-to-day life, right? So these speech and there's a MSc in swallowing, MSc in speech, right? If I'm right. There are few places like Amrita in Kerala has MSc in swallowing. They have a very good facility with them. They do swallowing, lot of swallowing rehabilitation there, and it itself is a very big branch, deglutition and swallowing. Yeah, have you gone and somewhere to any conference? There was recent conference in Goa, right? You have attended? Nobody has gone. Conference in Goa, conference in even in Amrita they have conducted last 6 months. The Goa conference was in January. Acha, one. You have to what we call as interact with the doctor clinician. You have to every patient you go in. So every patient who comes in our OPD says with comes with a voice or a swallowing issue. The most common complaint of a female after 45 years, they come with, they say that I have something in my throat. There's a foreign body sensation in my throat. They try to clear their throat. They say my voice is not clear. So that's the point where you have to come in actually. And actually there's lot of clinical applications of a speech language pathologist in day-to-day life, right? Sure. These are my references from various textbooks and Google Images, YouTubes, and that's it. Thank you. References, these are textbooks. These are all otolaryngology textbooks. Scott Braun, Cummings, especially the for. So there's another textbook by for swallowing. If you want swallow to read on swallowing, there's a textbook by um, Dr. Krishna Kumar Tangappan. He has recently published it in 2019 or 18, I think. It's a very good textbook on swallowing. Uh, we have a limited, look, all these textbook would have reference articles, and from there you could take the references and read those papers. Actually, you have to read the articles and papers, right? These are basic information. Probably the references in these books will give a further information on the topics. Any other doubts? Anything you want to ask? Dysphagia, first, the most important thing is evaluation is most important. How do you evaluate? What sort of patients come to you with a dysphagia? What's the primary complaint? What is their background? Have they undergone any treatment? Have they undergone any surgery? Have they undergone any radiation? Or is just neurological sequel? So there are three different ranges, what we call the different range of disabilities. If it's a neurological thing, then probably there are different approach. If it's a surgical or radiation thing, there's a different approach. And you have to prehabilitate, not rehabilitate. Rehabilitation is once you get a disease, you treat them. After that, you rehabilitate. Prehabilitating is treating the patient and by anticipating the what we call as his morbidity beforehand. Suppose I know that this patient is a malignancy or cancer patient, CA larynx, who is going for radiation. So you should know that he would develop swallowing difficulty during the radiation, after the radiation. So you can give him exercises beforehand so that he practices it daily, so that the recovery will be fast and the side effect will be very less. You have to prehabilitate. So you have to work in conjunct with your doctor to think about it, to work on it. So dysphagia evaluation itself is a very big topic. You have different modalities to do that. You have fees, functional evaluation of endoscopic evaluation of swallowing. You have video fluoroscopy. You have modified barium swallows, and you have various menus to do that. So fluoroscopy is it's a different setup. You need X-ray and all those stuff. But fees could be done in a setup where there's an ENT or otolaryngology setup. You have the fiber optic endoscopy, so you can do there with different consistencies. Any other doubts? Anything? Not only related to anatomy, anything in speech and voice related. How many of you use that VHS, voice handicap index, GRBS scale? They use day in day out, right? That's good. Fine. Thank you then.